Thank you for being here. Today we have one of our fellows in training, Dr. Abhinav Sharma. Dr. Sharma graduated medical school and completed his internal medicine training at McMaster and completed his cardiology training at the University of Alberta. He's currently completing his PhD in medicine under Dr. Justin Ezekowitz and his cardiovascular research fellowship under Dr. Mike Felker. He's received Young Investigator Awards from the American Heart Association and the European Society of Cardiology. And he hosts the inaugural DCRI podcast, Science is the Best Medicine. And when I heard this, I thought that it was really a shame that it's only broadcast in audio format because it deprives viewers of one of Abhinav's most famous assets, which is his personal style, for which he recently won an award, a Fellows Award for Snazziest Dresser. So please, yes, very auspicious. The competition was not that steep, was it? So please join me in welcoming Dr. Abhinav Sharma.
Well, thank you, Emily. Well, so thank you very much for coming today. My name is Abhinav Sharma, and I'll be presenting on finding the sweet spot in treating patients with diabetes and heart failure. So here are some of my disclosures. So today we'll be going through the scope of the problem, specifically focusing on this patient population of diabetics who have heart failure. We'll run through some of the pathophysiology and mechanisms. We'll take a look at the causes of death amongst patients across a spectrum of dysglycemia, so looking at pre-diabetic patients, diabetic patients with atherosclerotic disease, and then diabetic patients with heart failure, and comparing these groups. And then we'll take a look at some of the therapies that have been evaluated in these patient populations, so looking at anti-hyperglycemic medications and heart failure therapies. And then we'll wrap up by looking at some of the knowledge gaps and evaluating what are some of the directions in terms of moving forward. So in terms of the scope of the problem, heart failure affects more than 5 million adults in the United States and currently costs healthcare systems over $30 billion a year. Diabetes is even worse and infects over 29 million adults and costs over $176 billion a year. So that's basically the population of California right there. And by 2050, it's projected that 1 in 3 individuals is likely to have diabetes. So if you look around the room here today, 1 in every 3rd individual is potentially projected to have diabetes by 2050. And the costs are expected to balloon to $336 billion a year. And so combined, the public health and economic consequences of these two disorders are absolutely formidable. And so what about this combination, this intersection of patients with both diabetes and heart failure? Is this an emerging epidemic? Well, we took a look at this data using the Get With The Guidelines Heart Failure Registry. We evaluated over 200,000 patients, and the Get With The Guidelines Registry focuses on patients who've been admitted in hospitals across the United States with heart failure. We took a look at the prevalence of non-cardiovascular comorbidities, including diabetes, and what we saw, as highlighted in the red box, was that diabetes from 2005 to 2014 has been increasing over time. So the prevalence has been going up. And not only that, but it's the most common, essentially, comorbidity amongst patients with heart failure. Initially at 40%, but now above 46%. So basically, almost half of all patients with heart failure appear to be having diabetes. It's extremely prevalent. And what about risks of outcomes in terms of incident heart failure and recurrent heart failure? So this was data published by Cavender looking at the REACH registry, which was a population of older adults. And what they showed was that compared to patients without diabetes in the black box, patients with diabetes in the gray box had a significantly increased odds of developing incident heart failure or recurrent heart failure, regardless of the other comorbidities that they have. And this has been replicated across multiple cohorts. If you have diabetes and heart failure, your risk of adverse events absolutely skyrockets. So the takeaway points is that combined, the prevalence of diabetes and heart failure are increasing over time. They pose a significant burden on healthcare systems, and diabetes independently increases the risk of incident and recurrent heart failure events. So in terms of this increased risk, is it just because diabetes accompanies a whole lot of other disorders, or is there something else going on? So when we look at the pathophysiology, we could see that diabetes often is accompanied by hypertension, so high blood pressure, coronary disease, renal disease, and is it just this conglomeration of comorbidities that leads to heart failure, or are there other mechanisms in play? Inflammation, mitochondrial dysfunction, fibrosis, triglyceride deposition, abnormal calcium handling or RAS system dysfunction? Are there other things that are going on that are driving the development of heart failure and the adverse outcomes that we're seeing? So in terms of a bit of a historical perspective, this concept of a diabetic cardiomyopathy was developed in the 1970s in a post-mortem of about 27 patients who were diabetic and had complications of diabetes. 23 of them had other disorders, high blood pressure, coronary disease, or valve disease, but there were 4 patients that were essentially pristine, that didn't have other comorbidities, and they had hearts that looked like hearts from other disorders, such as Chagas disease, alcohol-induced cardiomyopathies, or even these primary cardiomyopathy as well. And when we look at slides, I'm just going to walk around here and use this pointer, we can see that there's very extensive fibrosis and increased diameter of the myocyte cells, so they're very hypertrophied. And when we look at the arterioles, we can see that it's essentially chocked full of this acid-staining mucopolysaccharide. So the overall message was that diabetes inherently may have a direct toxic effect on the heart that resembles a lot of other disorders. In order to evaluate this further, we took a look at data from the PROTECT trial. So the PROTECT trial looked at relaufolin, which was an alpha-1 receptor antagonist in acute heart failure. It was an overall neutral study, but this trial randomized essentially 2,300 patients who were in acute heart failure. 922 patients were diabetic, and very interestingly, a panel of 48 biomarkers were measured at baseline. So we use a statistical technique known as network analysis to assess the relationship of biomarkers to each other. Now, what is network analysis? This is a tool that's been used primarily in the cancer literature to identify how gene expressions are related to each other in tumor cells. And so we've taken that statistical technique and applied it to this panel of 48 biomarkers. And we measured biomarkers across a spectrum of disorders here, or a spectrum of pathophysiologic domains: inflammation, anemia, renal function, atherosclerosis, cardiomyocyte stretch, angiogenesis, oxidative stress, remodeling. Basically, whatever mechanisms we could think of that could be relating to adverse effects, we measure them in this particular cohort. And so when we did a first pass, just to see, well, what biomarkers are elevated and what biomarkers are depressed in patients with diabetes, we see a pattern emerging. There are about 10 biomarkers that seem to come up. So pentraxin, TNF-alpha, D-dimer, and periostin, these are established biomarkers. So those are the ones over here. These are established biomarkers of inflammation and thrombosis. So some of them were decreased in patients with diabetes. TNF-alpha was increased. Cardiomyocyte stretch marker, BNP, was decreased in diabetic patients. VEGF, angiogenesin, LTBR, these are known markers of angiogenesis and atherosclerosis. These markers were differentially expressed in patients with diabetes. NGAL and KIM1, which are markers of renal function, were differentially expressed as well. So already, we're beginning to see that patients with diabetes, compared to those without diabetes, have different expressions of biomarker, even after adjustment for age, sex, comorbidities, and medications. So this was our network analysis, and I'll spare you your eyesight and summarize it in the next slide here. And basically what we saw with our cluster analysis was that there was this molecule that came up again and again, called periostin. Periostin has been implicated in a lot of bone mineralization problems and is now being identified as a key molecule in a lot of progression of cancers. What we saw was that in patients with diabetes, but not in patients without diabetes, periostin was significantly associated and correlated with CRP and interleukin-6, suggesting that fibrosis and inflammation were highly correlated in these diabetic patients, and this finding was not seen in patients without diabetes. We also saw that potassium, creatinine, and NGAL were closely correlated together. So what this means is that whenever one of these biomarkers were elevated, the other ones also seemed to increase as well, suggesting that there was a renal cluster or potential renal influence in patients with diabetes. Again, a finding not seen in patients without diabetes. And finally, we saw that glucose, triglycerides, and cholesterol were closely correlated with each other as well. Now, this was actually a very reassuring finding because we know in patients with diabetes, the primary problem is that they have inability to regulate glucose, triglycerides, and cholesterol. So the fact that this came up in our network analysis almost proves as some sort of validation of the statistical techniques we were using. And so, to summarize that, the takeaway points for these mechanisms is that there appears to be a distinct mechanism of myocardial damage in patients with diabetes and heart failure. It's not just a confluence of comorbidities, but comorbidities do play an active role. We know that periostin, which is implicated in these other disorders as I mentioned, may be playing a role in the pathophysiology or development of adverse outcomes in patients with diabetes. And potentially targeting the periostin pathway may improve LV function and outcomes in patients with diabetes and heart failure. Now, very interestingly, in a lot of the cancer literature, they're developing molecules to target the periostin pathways. So it'll be interesting to see what type of outcomes they see and whether any of those results can be translated into the heart failure world. Now, moving on from mechanisms, if we really want to implement interventions that can affect quality of care and systems of care, we need to understand how and why these patients are dying. So we took an analysis of patients across a spectrum of dysglycemia, and dysglycemia here I've defined as patients with prediabetes, so impaired glucose tolerance, those who have established diabetes and coronary disease, and patients with diabetes who have heart failure. So we looked across a spectrum of these disorders. And we assume that patients with dysglycemia have a large burden of cardiovascular death. But actually, when you look at the literature, the causes of death amongst patients across the spectrum of dysglycemia is relatively unexplored. And this has significant implications for clinical trials and systems of care that are trying to reduce the burden of CV death. So we started off with analyzing the Navigator trial. So the Navigator trial enrolled 9,306 patients with impaired glucose tolerance and cardiovascular disease, or at higher risk of cardiovascular disease. And these patients had a median follow-up of about 6 years. The overall study randomized patients to nitaglonide versus placebo or valsartan and placebo. And the primary outcome was progression to diabetes or cardiovascular death, MI, or stroke. So co-primary endpoints. The overall trial was completely neutral. So essentially we had this cohort of 9,306 patients that we used, and given that all the deaths were adjudicated, we evaluated, well, what was the burden and distribution of the causes of death? So in total, 622 patients died. And very surprisingly, we found that 51% of all of these deaths were non-cardiovascular. Now, non-cardiovascular is like a hodgepodge of disorders, from renal function to malignancy, et cetera. But in this trial, it was an unexpected finding, given that we assumed patients with prediabetes are at higher risk of cardiovascular disease, and these patients were enriched for cardiovascular events because they already had pre-existing cardiovascular conditions. Yet the majority of deaths here were actually non-cardiovascular. And when we broke that apart, in the red box, we can see that malignancy formed over 29%, or about 29% of all causes of death. So this is a bit of an unexpected finding for us here. Now we also looked at causes of death in the TICOS trial. So the TICOS trial was actually looking at patients with diabetes, and they had established atherosclerotic disease. So they had a stroke or an MI or peripheral vascular disease. 14,000 patients were randomized to sitagliptin versus placebo. Sitagliptin is a DPP-4 inhibitor, and I'll talk about that in just a second. Basically, the overall trial was neutral. No increased risk of adverse events was associated with sitagliptin. But in total, of all the patients, there were around 1,084 deaths. And what we see is that 49% of these deaths were cardiovascular, and non-cardiovascular deaths formed 31%. So still, even in this enriched population, while CV death was the majority of deaths here, non-cardiovascular death still formed a large burden of overall mortality. Now let's break apart the CV death a little bit more. What we found was that sudden death formed the most common grouping of adjudicated causes of death at 27%, followed by acute stroke and MI, followed by heart failure. And there's this other sort of hodgepodge category of presumed and other deaths. But what was most striking is that sudden death was the most common cause of death. Now, we don't know the underlying mechanism of sudden death. Did they just have a massive heart attack while sleeping, or a massive stroke? Was it arrhythmic? It's a little bit difficult to tell. But what was surprising was that strokes and MIs was not number one, which is what we would have assumed. Now, we took a look at another cohort. Again, diabetic patients. Sorry, let me take one step back here. This particular cohort here was a very unique cohort in where we combined the HF action data with the Asian HF data. So the HF action is a randomized trial that enrolled patients with chronic heart failure and randomized them to exercise versus standard of care. There was a modest reduction in cardiovascular events. This was combined with the Asian HF cohorts, and the Asian HF cohort is a prospective longitudinal registry of patients in Asia. So here we have actually a very nice heterogeneous cohort of patients with chronic heart failure, multi-centered, multi-ethnic, and I'm working on this with Carolyn Lamb and Rob Mentz. Here in total, we have around 6,962 patients with chronic stable heart failure and LVEF less than 35%. And what was very striking and what was very nice about this cohort is that we have adjudicated causes of death and very similar adjudication in both categories, in both cohorts. So overall, there were 560 patients who died. And what we saw is that in this patient cohort, the burden of death has shifted almost significantly to cardiovascular death. 61% of patients are dying from cardiovascular causes, only 15% from non-cardiovascular causes. And when we break it apart a little bit more, sudden death is still the most common cause of death at 45%, and heart failure death at 37%. MI and stroke is down there at 11%. So let's just summarize all this information here. What we can see is when we move from the Navigator trial all the way to the combined cohort, so pre-diabetic patients all the way to diabetic patients with heart failure, the burden of cardiovascular death significantly increases. The burden of non-cardiovascular death significantly decreases. And sort of unknown deaths, I just put it there for reference here. But if we were to target interventions, for example, that are trying to reduce the burden of non-cardiovascular disease in a diabetic patient population with heart failure, we're not really going to be having much change given that most of the deaths are cardiovascular. Conversely, if we're to implement strategies to improve non-cardiovascular outcomes in patients with prediabetes, that may actually have a lot of impact. So knowing the population and knowing that the modes of death will help target interventions and strategies amongst these patients. And now when we look at cardiovascular CV death in specific, we see that sudden death significantly increases as we go from a pre-diabetic patient population to a heart failure population. And we see that the MI stroke death significantly decreases. So again, if we're trying to reduce MI strokes in a heart failure patient population with diabetes, we may not get a big bang for our buck compared to, say, pre-diabetic patients who have a high burden of CV death, CV death related to heart attacks and strokes. Now, as we can see with heart failure, it's a little bit more heterogeneous, but clearly patients with heart failure and diabetes have more heart failure deaths, so that's an expected finding. So takeaway points, we are shifting the burden of death from non-cardiovascular to cardiovascular as we move from pre-diabetic patients to diabetic patients with heart failure. And the causes of death are also changing. So I think we have to be careful when we're looking at interventions and strategies to improve outcomes, because we could be underpowering our studies, or we may not be looking at the right intervention, given that the risk of these events are so different depending on our cohort. Now let's take a look at some of the heart failure therapies in patients with diabetes. And the one that I want to focus on is ICDs. Why ICDs in particular? Well, they're expensive, they're invasive, there could be complications associated with ICDs. And ICDs specifically are these implantable cardioverter defibrillators that are implanted in patients who have reduced ejection fractions in order to prevent arrhythmias and life-threatening arrhythmias. So, I wanted to evaluate the comparative effectiveness of ICDs in patients with diabetes. And what we did was that we did a patient-level meta-analysis, so I worked with Dr. Sana Al-Khatib on this, and we looked at the 4 primary prevention ICD trials. So it's MADIT-1, MADIT-2, DEFINITE, and SCUD-HEF. So we took all of these trials, and within all these trials, patients were essentially randomized to an ICD or to medical therapy. So 996 patients were diabetic, and 2,363 patients were non-diabetic. The primary outcome was all-cause mortality, and in each individual study, when you look at the primary outcome, ICDs were associated with a reduction in all-cause mortality. That's why we have an indication for them now in current practice. So diabetic patients, essentially the age, the sex, the LVEF, you can see the first 3 lines were essentially the same. Ischemic heart disease was higher in patients with diabetes, as we would expect. ACE inhibitor use and beta blocker use was about equivalent. Now I want to highlight this point here because these trials were relatively old, and ACE inhibitors and beta blockers are known to improve outcomes in patients with heart failure, yet the use of it was fairly low given that these were older trials, and it may not be translatable to current practice. So very surprisingly, what we found was that when patients who were diabetic were randomized to ICDs compared to those who were randomized to medical therapy alone, there was essentially no change or no divergence of these curves until about the 4-year mark. Hazard ratio was 0.88, so it suggested maybe some benefit, but the confidence interval crossed 1 and a very non-significant p-value here. And to compare that to a non-diabetic patient population. So the dotted line are those who are randomized to ICD. The red line are those randomized to medical therapy. A clear reduction in mortality from very early on, hazard ratio that was significant, confidence interval on the right side of 1. And there was a significant interaction term between the non-diabetics and the diabetics. So what this implies is that diabetes somehow modifies the relationship or reduces the magnitude of effect of ICDs on all-cause mortality. We still don't have a clear explanation for this finding. Potentially, it's because these diabetic patients may be at higher risk for other competing causes of death, or they have other reasons for becoming or having sudden death, which an ICD would modify. But we don't have a clear explanation for this particular finding here. And so if we move away from heart failure therapies and look at anti-hyperglycemic therapies, so basically drugs that will help control sugars, let's take a look at some of the evidence of that in patients who have heart failure. Just as a little bit of a backdrop, prior to 2007, if you had an anti-diabetic drug that you wanted to put on the market, you essentially ran a trial, you showed that you could control your sugars better as measured by a protein called HbA1c, you got it on the market. This study here in 2007 by Steve Nissen demonstrated that one anti-diabetic drug, rosiglitazone, significantly increased the risk of MI and cardiovascular death. Since then, to 2008, or after 2008, the US FDA put forth guidelines for sponsors to demonstrate that their anti-hyperglycemic medications do not increase the risk of cardiovascular disease and death. So that's why we now have a whole slew of trials that are looking at outcomes in these anti-diabetic drugs. But the relationship between diabetes and cardiovascular disease was traditionally believed to be atherosclerotic in nature. Most people focused on the MIs, the strokes. Heart failure as an outcome was largely ignored. And so this brings up two major issues that remain relatively unexplored. One was the risk of heart failure itself due to anti-hyperglycemic medications. And two was the safety of therapies safety of these anti-hyperglycemic drug therapies in patients with diabetes and heart failure. We actually took a look at this at the completed trials that were out there in the literature. And overall, 33% of these trials didn't even have a definition for heart failure events. So it was clear that heart failure was really not on the minds of the investigators who were doing these studies. But what we also saw was that heart failure definitions have been changing over time. And this is likely because we were recognizing that heart failure is an important outcome in these patients. And this was a meta-analysis done in 2015, looking across the spectrum of anti-diabetic drugs. So essentially all anti-diabetic drugs were put into this meta-analysis, and this was also divided based on specific classes and categories of drugs, but similar results were seen. And basically you can see, well, it's not coming up very clearly here, but for most of the outcomes, all of them are roughly around 1 or maybe slightly favoring glucose lowering, except for heart failure. Heart failure seemed to be the only outcome in which these therapies appear to have an adverse outcome. So now let's dive into some of these therapies here. So one of these drugs I mentioned was the dipeptidyl peptidase 4 inhibitors. What these drugs do is when you take in glucose, it increases a level of these molecules called incretins. And these DPP-4 inhibitors prevent the incretin breakdown. As a result, the downstream effect is to increase insulin, decrease glucagon, and decrease sugars. The real interest in heart failure was sparked by this trial here, the SAVOR-TIMI 53 trial. 16,000 patients, they had documented diabetes, and they had cardiovascular risk factors. They were randomized to saxagliptin or placebo, followed for about 5 years. Primary endpoint was CV death, non-fatal MI, non-fatal stroke. Overall, the entire trial was neutral, so great. The drug did not show an increased risk of the primary endpoint. But when they looked at the heart failure outcomes, a very surprising result came. Saxagliptin, as highlighted by the red line here, significantly increased the risk of heart failure hospitalization compared to placebo. The early risk at 1 year was around a hazard ratio of 0.46, so a 46% increased risk. of outcomes. And so this really triggered the interest in heart failure outcomes amongst diabetic patients, because it could be that these drugs that we're using to control sugars may be worsening heart failure outcomes. The TICOS trial, as I mentioned previously, randomized 14,735 patients to sitagliptin versus placebo. Sitagliptin is another one of these DPP-4 inhibitors. The results here were totally neutral. No increased risk of heart failure outcomes, hazard ratio of 1. The other trial that was there was the EXAMINE trial. So this was the third DPP-4 inhibitor trial, looking at this drug called allogliptin. And the EXAMINE trial looked at 5,380 patients, and so they were randomized to allogliptin versus placebo. And I just want to draw your attention to the outcomes here. And we could see that there appears to be a slight increased risk of heart failure hospitalization amongst patients who were randomized to allogliptin, hazard ratio of 0.19, confidence interval though crosses 1. And if we look at CV death and heart failure hospitalization, really neutral outcomes, but potentially a possible increased risk of heart failure. It's a little bit unclear based on the data that we have. Although when a meta-analysis of this was conducted, you could see that overall there appears to be a trend towards possibly increased risk of heart failure outcomes when we combine all of these three drugs together. And in fact, the FDA has recently released a warning for saxagliptin and allogliptin with regards to the risk of heart failure outcomes. Now I want to briefly highlight two other categories of drugs for you. So we looked at the DPP-4 inhibitors, and some of them may increase heart failure risk, some of them may not. The results are a bit conflicting. With regards to this other category, SGLT2 inhibitors, some interesting results have come about recently. SGLT2 is a protein that's found in the proximal tubule within the nephrons in the kidney, and their primary function is to resorb glucose. What these SGLT2 inhibitors do is that they prevent this glucose reabsorption, and you essentially diurese out your glucose, and that's how you drop your sugar level in your blood. So these are some of the slides that I've taken from the EMPA-REG group, and this SGLT2 inhibitor, empagliflozin, rather a convoluted name here, was one of the first that had outcome data. Preliminary data suggested that in patients with type 2 diabetes, this drug reduced HbA1c, so a measure of glucose control, caused weight loss, and reduced blood pressure. So all good things. This was evaluated in a trial called the EMPA-REGS outcome trial. So it randomized 7,000 patients to placebo and 2 doses of empagliflozin, and all patients had established cardiovascular disease. So very similar to the patient population we've seen in TICOS. Overall, in comparison to the other outcomes that we've seen, there was a 14% reduction in CV death, non-fatal MI, or non-fatal stroke. So this was actually one of the first drugs to show a mortality benefit associated with an anti-hyperglycemic therapy. When we dive into this in a bit more detail, we could see that heart failure hospitalization risk was reduced by 35% associated with empagliflozin use. This is very different than the DPP-4 inhibitor, saxagliptin, which almost increased it by 40%. The third drug category I want to talk to you about is the so-called glucagon-like peptide 1, or GLP-1 receptor agonist. It has a variety of function. The bottom line is that these GLP-1 agonists increase glycogen storage, so they increase glucose storage, and in the fat cells, increase glucose uptake and lipolysis as well. So amongst patients with heart failure, there was a trial that was done through the Heart Failure Network called the FIGHT study, or the FIGHT trial. And this study, you looked at liraglutide in patients with advanced heart failure and reduced ejection fraction. So in the FIGHT style, they randomized 300 patients with EF less than 40%. So these patients were both with and without diabetes. They were recently hospitalized with heart failure, and they were randomized to liraglutide or placebo. The primary endpoint was a global rank score, so looking at time to death, time to rehospitalization for heart failure, and changes in NT-proBNP from baseline to 180 days. Overall, the study was essentially neutral. There was no change in the mean global rank score between liraglutide and placebo. Now, liraglutide is also associated with weight loss, and it actually has an FDA indication and approval for weight loss. So along with my colleague Andrew Ambrosi, we did a post hoc analysis looking at weight change in this population. And what we found, and this is a little bit of a complicated figure here, but essentially the absolute weight change, so the patients who lost the most, were predominantly on liraglutide by the blue bars. We could see the same thing for the relative change as well. So liraglutide patients, or patients who are randomized to liraglutide, lost more weight, as we expect. And overall, we could see amongst diabetic patients, the HbA1c was better controlled, as reflected by significant changes in the HbA1c percentages. They had better control of triglycerides. So all pointing towards good things. HbA1c is better, triglycerides are better, they're losing weight. But then when we take a look at the subgroup of patients with diabetes, an interesting signal arises. We can see that overall, there appears to, at least when you look at it visually, a higher risk of outcomes of death or rehospitalization for heart failure amongst patients who are randomized to liraglutide versus placebo. Hazard ratio of 1.5 with a confidence interval of 0.97 to 2.46. Now, this is a small group of the overall population. There was no interaction term between the diabetics and non-diabetic groups. But when you see the raw events and the raw numbers, it causes you to think, could this drug potentially be increasing or worsening outcomes amongst these patients? And so summarizing this, what exactly do the guidelines recommend? What do they give us in terms of guidance? And with regards to anti-hyperglycemic medications, given how complex this field is, some drugs increase risk, some drugs decrease risk, there's some drugs where we don't know exactly what's going on. The guidelines are unfortunately rather generic. So this was released in 2016, a dedicated document to look at how do you manage diabetes in heart failure patients. We could see that the class of recommendation is 2B, level of evidence C, level of evidence B. Really not a lot of high quality data out there in terms of guidance. Overall, the guidelines recommend, well, if you have diabetes and heart failure, you should go on metformin, which is one of the first line agents. And really, after that, there's inadequate data to make recommendations on other anti-diabetic agents. And now I've shown you a whole variety of anti-diabetic drugs. So we, as clinicians, have a hard time deciding, well, what should I be putting these patients on, or what should I be avoiding if a patient with heart failure comes to see me and they've had a hospitalization recently? Should I be changing their anti-diabetic drugs? Will it help? Or will I make things worse? So the takeaway points with regards to therapies are that anti-hyperglycemic agents have conflicting evidence regarding heart failure risk amongst patients with both heart failure and diabetes. There's limited guidance from consensus statements, mostly because there's not a lot of high-quality evidence. When we look at heart failure therapy, such as ICD, we have to recognize that there may be a reduced magnitude of benefit in patients with diabetes. That doesn't mean that these diabetic patients shouldn't be getting an ICD. And that study was limited in that we didn't have a lot of data on duration of diabetes or how well controlled it was. But it definitely serves us to think that maybe not all therapies are best for certain populations. And dedicated studies are needed amongst patients with diabetes and heart failure to ensure safety and efficacy. Because as we've seen, some therapies may be increasing the risk of heart failure, some therapies may be decreasing it, some therapies may not be effective at all. So to wrap up here, what are some of our future directions and future endeavors? Given that a lot of these studies, in terms of looking at diabetic heart failure patient population, it'd be very hard to do a randomized trial in it, in terms of enrollment, recruitment, and interest from sponsors and other groups. Another way to look at this question is to do population-level comparative effectiveness analyses. While they have their limitation, they may actually give us some clues or some signals as to harm of therapies. We also need to be doing a better job in terms of identifying patients with diabetes at high risk of incident heart failure or even recurrent heart failure. If you could identify patients that may be at high risk of developing heart failure down the road, maybe we can intervene or give them therapies or drugs or give them other strategies to help reduce that risk. Because as I've shown you, when you develop heart failure, your risk of outcomes down the road are really abysmal. And also, I've been sort of focusing on the pharmacologic and device therapies, but what about non-pharmacologic strategies? Are there any things we could do to actually help improve outcomes in patients with diabetes and heart failure through a non-pharmacologic strategy? So very recently, the DCRI in Duke here was one of the sites selected to be a part of the AHA Strategically Focused Research Network grant. And this is a collaboration of projects here led by Swati Shah, who's doing the basic project, Dr. Mike Felker doing the clinical project, and Adrian Hernandez doing the population project, and Joe Rogers involved in the training program. And I was fortunate enough to be a co-investigator on this and helping with some of the projects. And so one of the population projects that we're looking at is the sort of impact HF, or improving population health for patients with diabetes and heart failure. And so overall, we're using data from the Duke Health System database and with that national Get With the Guidelines heart failure registry that I mentioned. We're looking at this population of patients with diabetes and heart failure to identify population level risk, to identify phenotypes of patient at risk, and to look at comparative effectiveness analyses. So how do we know what's the best first-line agent? How do we know what's the best second-line agent? We can get clues into those answers or those questions with this type of data. And hopefully this will lead to decision tools and knowledge translation that can help implement future studies and help guide practice. In terms of identifying high-risk patients, this is another project that I'm involved in, the Examine trial through a European Society of Cardiology grant that I was able to get. We have about 5,000 patients in the Examine trial that I mentioned. That was the one where patients were randomized to allogliptin versus placebo. And of these 5,000 patients, we have 6 biomarkers on all of them: NT-proBNP, GDF15, troponin, fibroblast growth factor, interleukin, galactin. And we're using this to create predictive models to identify who is at high risk of developing incident and recurrent HF or heart failure. And then finally, again, through this AHA grant, Dr. Mike Felker is leading one of the arms, and this is a randomized trial called Target DMHF. So this is technologies to improve drug adherence and reinforce guideline-based exercise targets in patients with heart failure and diabetes. So the hypothesis is that a personalized mobile health intervention can help increase physical activity and improve medication adherence, things that we know will improve outcomes among patients. So overall, patients with heart failure and diabetes are randomized. Around 200 patients will be randomized to a mobile health intervention and to usual care. The mobile health intervention, or through the intervention, they'll be getting regular messages to say how much you've walked, how much exercise have you done, have you been increasing your exercise levels from week to week. It'll also track through a device developed here at Duke called the Duke Pill Box how adherent they are with medications. So this mobile health intervention will be in one arm and usual care will be the other arm. And after the end of active follow-up, we'll follow them up for several more months to see if there's persistence or adherence of this data. So this is one attempt at a pharmacologic strategy to help improve outcomes in patients with diabetes and heart failure. So with that, I just want to acknowledge my PhD supervisor, Justin Zekowitz, and Dr. Mike Felker, who's my Duke Research Fellowship supervisor, Dr. Zanad, who I'm collaborating with on the ESC grant, and Dr. Adrian Hernandez and Joseph Rogers for their mentorship and all of their support. So thank you for your time, and I'm open to any questions.
That was a great overview and really impressive scope of things that you're thinking about and working on. There's a lot of different things that I could potentially engage with some enjoyment, but I'll restrict myself to the analysis that you did on the defibrillator. Mm-hmm. I happen to have been thinking about sort of similar things recently. And so I wonder if it isn't possible to drill into this a little bit more, since we actually have some of these data. And what I mean by that is, so if you're saying that for some reason the defibrillator doesn't appear to be as effective as expected in the diabetic, and you were actually thinking about why would diabetes do this, but before I would go to that question, I guess I would try to figure out if things we already know might explain this finding. And the easiest way to drill into that, I think, would be to see what's the appropriate shock experience in the diabetics. Are those shocks being delivered? Are they being successful? I mean, is there more refractory ventricular fibrillation in diabetics? Is the proportion of non-cardiovascular, non-ICD treatable deaths from whatever cause increased so that the hazard ratio is approaching the null position, even though there may be individual patients whose lives are being saved with diabetes? We certainly have the SCUT-HEF data available. MADA-2 has the same data. I don't know if we can get access to it, but so at least 2 of those 3 trials, you'd be able to look at all of those diabetics and see what actually happened.
So that's a great point, and we actually have gone into that. For the sake of time, I didn't present all of the data, but what we do know is that when we compare shock rates between diabetic and non-diabetic patients, they appear to be predominantly the same. And when we look at inappropriate versus appropriate shocks, also they appear to be the same between the groups. You're absolutely right. I mean, we repeated the analysis looking at arrhythmic versus non-arrhythmic death. And what we do see is that there is definitely a high burden of non-arrhythmic death in these diabetic patients. So there may be an issue of competing risk here, that these diabetic patients are dying from other causes faster than they would of sudden death, or at least of arrhythmic death, I should be clear. And those non-arrhythmic deaths are not going to be modified by an ICD. So that's one potential explanation that we have, that non-arrhythmic death form a large burden of mortality. Even though sudden death is still the number one cause, as I've shown you, the overall totality of non-arrhythmic death essentially won't be modified by an ICD therapy.
Abhinav, yeah, I'll also compliment you. That was terrific. And ever since back in the CHARM trial that Mike helped do some analyses on, in our mortality model in that trial, diabetes was the single most important factor for predicting death, more important than age, ejection fraction, symptoms. Ever since then, I've been really struck by that. I think it's a really fascinating area with a lot of work that you've done nicely and a lot of additional questions. I was also interested in the ICD thing. I would suggest something much more simple as an explanation, and that is, what was the interaction p-value?
It was 0.01.
0.01. So, the interaction p-value, like for praise, was like less than 0.01, and it was play of chance. The famous statistician from Oxford, Richard Peto, calls the subgroup analysis a machine for generating false negatives. I would suggest by far the most likely explanation is the play of chance, although still worth, I think still interesting to look at.
That's not an explanation.
Yeah,
the play of chance is
not the most likely explanation.
No, it isn't at all. There's no explanatory power at all in that comment.
It's very powerful, very powerful. And then the other question I had was around the SGLT2 inhibitors, which is really interesting, and the ongoing work to see if they might actually be, similar to the kind of failed experiment with GLP-1 agonism, if SGLT2 inhibition might be actually beneficial in heart failure.
Absolutely. So to go back to your first point, we're actually trying to replicate our findings in other databases to see, was it just the cohort that we have? Can we see these findings in other databases? So hopefully we can get some either confirmatory results or some other results. And with regards to the SGLT2 inhibitors, as I showed with the EMPA-REG outcomes study, there's a 35% reduction in heart failure hospitalization. So they've now launched, so BI has now launched a series of trials called the EMPEROR trials, looking at patients specifically with heart failure and randomizing them to empagliflozin versus placebo. And so this is in patients with both reduced and preserved ejection fraction. So they're really hoping that this could be used as a novel heart failure therapy. So that was, I think, just launched this year, so the results will probably be available in the next 5 or 6 years. Mike.
Abhinav, great job. I mean, I think, Chris, you mentioned CHARM, and one of the things that's been really unique about this story is that it started out and people said just things like you said, well, diabetes is a risk factor, or if you have heart failure, you do badly. But what's really pretty unique is this emerging differential interaction with different, I sort of learned that whatever treatments used for diabetes, as long as they controlled the blood sugar, were more or less all the same. But clearly in heart failure, it's not just that one might be better than the other, but some might actually be harmful and others highly beneficial. So I think that's actually pretty unique in cardiovascular medicine. And it's, as a heart failure person, it's interesting to, I sort of see, that's the list of non-heart failure medications the person is on, and I can ignore those. But increasingly, I think we're going to be asked to weigh in on what diabetic treatment people are taking or should be taking, which is going to be a pretty unique situation as this moves forward. And I'll echo what other people said. You know, you've done an amazing job pulling all these different threads together over the course of your time here. So
Thank you.
congrats.
To that specific point, just a practical clinical question. When can we and when should we not use metformin in patients with heart failure?
So that's a great question, and I was actually just talking about this with Mike earlier, that there was a time when metformin was just contraindicated in patients with heart failure. But now the FDA has released new guidelines to say that unless you have really impaired kidney dysfunction, or unless you've just been hospitalized with heart failure and you may be expected to have a lot of hemodynamic issues, metformin is still really the first-line agent for patients with diabetes who have heart failure. So it's fairly safe, and really almost all the major meta-analyses haven't shown an increased risk of outcomes. The big risk, what people were worried about, was lactic acidosis. So metformin is, in the context of kidney dysfunction, appears to cause an increase in lactate. These patients would come in fairly sick. pH was very low. They were, often have to go to the ICU. But really, these large meta-analyses and large population health analyses haven't shown this risk. And so I think that it can be used fairly liberally as long as you're sure that the kidney function isn't going to change, and as long as they're not expected to have a lot of changes in their hemodynamics.
What degree of renal impairment would you use as guidance?
I mean, it is an interesting story because when I trained, it was when metformin first came out, and we were told, like, don't use it in heart failure patients. I know you had been well advanced in your career at that point, but I, like a lot of things, I think the concern about metformin was kind of a little bit overblown, this whole lactic acidosis thing. So unless you have very substantial renal, I don't know why I can't give you a credit.
Usually less than 30.
Yeah, so I mean, I think
far less than 30. Yeah.
it's the safest. Although I think if you were, and again, the degree to which a heart failure doctor may or may not be weighing in on this, there's no data that I know of to support the idea that metformin provides a cardiovascular benefit if you have heart failure, where at least there's the strong suggestion that empagliflozin does. So I mean, the current guidance is metformin is the safest one, but I think that's going to be evolving quite a bit in the upcoming years.
Rob?
I would echo the other remarks. Really nice presentation, I think, summarizing a complicated and quickly evolving space. I think an important point, and I'd be interested in your thoughts, how you reconcile the leader results with liraglutide that show this potential benefit, or this benefit in a large outcomes trial, with FIGHT, which is small and underpowered with respect to cardiovascular outcomes. And then you have increasingly sustained 6 showing GLP-1s are beneficial. We'll find out the Excel story that Adrian and others led here in a week. So I think it's an interesting time, and how do you reconcile these smaller data with large outcomes data that actually show overall in diabetics an outcome benefit?
Mm-hmm. That's a great question. So just to summarize, the LEADER trial was a very large outcomes trial that looked like liraglutide in patients with cardiovascular disease and who had atherosclerotic cardiovascular disease. About 9 to 10% of them had heart failure. And overall, that study didn't show any adverse outcomes in that heart failure subgroup. And overall, the trial showed that you can actually potentially reduce the risk of MIs and strokes. I mean, that's a great point, Rob. I think that the FIGHT trial was a very unique study population, and I think one that's often excluded from a lot of these other trials. So they were much sicker, so they had to be just discharged from hospital with heart failure. They had to have a previous heart failure hospitalization. They had to be on a high dose of loop diuretic therapies. So it is a sick population, and we know that these GLP-1 receptor agonists can often have a little bit of untoward hemodynamic effects, such as increasing heart rate and other metabolic changes as well that may be beneficial. But again, that speaks to the point that in these studies, this advanced heart failure population, or this population of heart failure, they're sicker. And I think we have to be very careful in how we use these GLP-1 agonists and other therapies in it. Now, as to your point as to how do you reconcile that, well, one big trial didn't show any outcomes and this one did. I mean, you're right, the FIGHT trial was small. It was underpowered to show those results. It was powered for the mean global rank, but it wasn't powered really for the heart failure outcomes. So it could very well be a play of chance, and if we did a larger trial, I may not see that signal. But For now, I think when looking at a heart failure population, a sick heart failure population, patients who are recently discharged from hospital or have high doses of diuretic therapy, I think we have to think of them in a slightly different manner than the other heart failure patients that are enrolled in these other studies, which in fact, they probably don't really phenotype them that well. They may have just had a history of heart failure at some point in time. It's usually a checkbox on the CRF, so we don't know a lot about them, and they may not truly be heart failure patients as well. So I think the LEADER trial provided an insight into a high-risk patient population, and it showed that we have to be very careful when looking at these larger studies because they may not have the granularity or the risk of patients that we're seeing in these smaller trials.
Just wondered, I remember the early literature on the diabetic cardiomyopathy, and there was at that time.
The one in the 70s?
Yes. That was actually my first lecture that I gave was on cardiomyopathy, and so I had to figure out something about it. And at the time, the idea was that there was a what we would call now a non-ischemic diabetic cardiomyopathy, perhaps due to microvascular disease, something similar to what happens in the periphery. But then over the years, interest in that seemed to sort of fluctuate a lot, and I wonder, from your vantage point, having looked at this recently, where are we with our understanding, and to what degree should we be trying to parse out the people who have some version of an ischemic cardiomyopathy that we already pretty well understand, maybe amplified by their diabetes, versus perhaps a rather very different type of heart failure with a different pathophysiology and perhaps different therapeutic implications.
No, that's absolutely right, and I think that's what a lot of the analyses that we're doing are trying to solve that. But really, we haven't made much in the way of advances in terms of identifying who are these sort of pure diabetic patients who don't have like coronary disease or valve disease or other causes, but have developed heart failure. We haven't moved much forward in terms of our understanding of that particular population. And it can be challenging because, again, a lot of these patients do still have high blood pressure. They will be obese. So the question is, what is actually influencing the heart? What is not? And in order to do those types of studies, you have to probably look at a very large proportion of the population and get invasive biopsies and that sort of detail that it'd be rather challenging to do. But I think there's a lot of merit in it. If we can identify why and how these diabetic patients or diabetes is directly cardiotoxic, that may give definitely unique therapeutic insights. And it could be that these diabetic patients with heart failure, there's multiple things going on. The coronary disease could be there, plus this extra insult from diabetes as well, as you mentioned. But that's definitely an avenue to explore.
So one of the things we're doing in our AHA grant that Swati's leading is we're looking at, and so all heart failure patients with diabetes have very altered myocardial metabolism. And so we're looking at both plasma and myocardial tissue from the tissue bank here in Colorado and diabetic versus non-diabetic hearts, trying to sort of create a signature of what the metabolic changes in the myocardium are in patients with heart failure versus patients with diabetes and heart failure. The traditional sort of diabetic cardiomyopathy was basically, there's no test for it, so it's sort of, you had cardiomyopathy and there was no other obvious cause and you had diabetes, so they said you have diabetic cardiomyopathy. So I'm not sure it's a very helpful label to that extent, but clearly all patients with heart failure have altered myocardial metabolism, and patients with diabetes and heart failure both have different forms of altered, the heart, depends a lot on glucose, and they have impaired glucose metabolism, which was one of the reasons we did the FIGHT trial, because the belief was that in these really sick heart failure patients, loragutide would actually help improve myocardial substrate utilization and improve myocardial efficiency, which certainly the signal was that it didn't seem to work.
Really good theory.
So anyway, so I think there's a lot still to figure out about this.
But I think another topic which I still find fascinating, and like Felker, the heart failure community ignores this, but I think it's incredibly important, is that we have these two trials with statins showing that statins have absolutely no benefit in patients who have low ejection fraction symptomatic heart failure. It's fascinating. Even in patients with prior coronary disease. And I wonder, have you looked at, you haven't happened to have looked at that in the diabetes subgroup?
No, we haven't parsed that out, or I haven't looked at that.
In my experience, the most common source of statin prescriptions in heart failure patients is actually the Duke CCU.
Understand.
So I think you're right, we should grapple with this issue but yeah, I mean, we see this all the time. I have patients with like end-stage heart failure and they're on the transplant list and they see their primary care provider who says, oh, you have a heart problem, you should be on a statin. So,
I mean, we've seen, at least from the diabetic results here, when you look at causes of death, the MI and stroke causes of death are so low, and that's predominantly where you would expect the statin benefit to happen. So, I mean, again, it may be a competing risk thing, that they're dying of other causes, and really the statin's not modifying that risk too much. Great. Thank you very much.